Dr. Rebecca Hartley, an ICU nurse at St. Catherine's Hospital in Baltimore, has dedicated 23 years to caring for the most critically ill patients, those teetering on the edge of life and death, necessitating continuous monitoring and intervention for survival. She has witnessed sights in the ICU that would unnerve most individuals, bodies succumbing in seemingly inconceivable ways, life support machines performing the functions that hearts and lungs no longer can, and families making heart-wrenching decisions about their loved ones. After more than 2 decades, she believed she had encountered every scenario critical care could offer, but she was mistaken. One Thursday evening in late September, a 62-year-old male patient, identified as Martin Kellerman, was admitted. He had collapsed at home during dinner with his wife. According to his records, he had no prior medical history, no chronic conditions, and was in perfect health. One moment he was eating and conversing normally, and the next he was unresponsive on the floor. His wife promptly called 911. Paramedics arrived within 8 minutes to find him in cardiac arrest. They successfully resuscitated him, restarting his heart, but he remained deeply unconscious. By the time Martin reached the ICU, his brain had been deprived of adequate oxygen for approximately 12 minutes, a critical time frame as brain cells begin to die after only 4 to 6 minutes without oxygen. While 12 minutes suggested significant damage was probable, recoveries from longer periods had been observed. The brain can be remarkably resilient at times, yet astonishingly fragile at others, making his outcome unpredictable. He was placed in ICU Bed 7, connected to all essential monitoring equipment, a ventilator assisting his breathing, intravenous lines delivering medications to support his blood pressure and protect his brain, a feeding tube, and a urinary catheter. An electroencephalogram monitored his brain activity, the standard setup for a patient in his condition. His vital signs were stable with mechanical support, but he showed no signs of consciousness, no response to voice, painful stimuli, or voluntary movement. The neurologist classified him as comatose, likely due to post-cardiac arrest encephalopathy, a brain injury resulting from the period of oxygen deprivation. His wife, Angela, was devastated, yet exhibited remarkable strength. She shared that they had been married for 38 years. Martin, a retired accountant, spent his days volunteering at the local library, teaching children to read. They had 2 adult children, both traveling from out of state. Angela directly inquired about his prognosis. Dr. Hartley provided the honest, standard answer in such situations. "We do not know yet." The next 72 hours would be crucial. They would monitor his brain activity, observe for signs of improvement or deterioration, and provide the best possible supportive care. The unusual aspect of Martin's case became evident within the first hour. His eyes would not close. While not uncommon initially in comatose patients due to affected eyelid muscles, they typically tape the eyes shut or use lubricating ointment to prevent corneal dryness. However, with Martin, every attempt to close his eyelids was met with a slow reopening over a minute or two, as if something were drawing them back. Dr. Hartley initially suspected muscle spasms or residual neurological activity. She applied medical tape, but it held for only about 5 minutes before slowly peeling away, progressively reopening his eyes. She tried different tapes and techniques with the same result. His eyes refused to stay closed. Dr. Chen, the intensivist on duty, examined him, noting the phenomenon but without excessive concern. Occasionally, after significant brain injury, peculiar neurological symptoms manifest, such as involuntary movements or unusual reflexes that defy standard patterns. He ordered additional electroencephalogram monitoring and instructed Dr. Hartley to apply lubricating drops hourly to protect Martin's eyes, given the inability to keep them reliably closed. It wasn't merely that his eyes wouldn't close. It was the way they moved. Most comatose patients either have their eyes closed or open but stationary, fixed in one position. Martin's eyes moved, exhibiting small, subtle tracking motions, as if following something. Dr. Hartley mentioned this to Dr. Chen, who observed for several minutes. The eye movements were undeniable, yet they lacked any predictable pattern and did not track actual objects or people in the room. Dr. Chen noted it in his assessment, but attributed it to random oculomotor activity, meaningless neurological noise emanating from a damaged brain. That first night, Dr. Hartley was assigned to Martin's care, along with 2 other critical patients. She checked on him every 15 minutes as per protocol. Each time his eyes were open, and each time she experienced an unsettling feeling that he was looking at something, not at her, nor at any specific object, but at something unseen in the room. She reasoned that she was being irrational. The man was comatose, and whatever his eyes were doing was involuntary and automatic. Around 2 o'clock in the morning, his wife departed for a few hours of sleep at a nearby hotel. The ICU was quiet, punctuated only by the ambient sounds of ventilators and monitors. Dr. Hartley was at the nurse's station charting when Martin's alarm sounded. Not a critical alarm, but a notification that one of his intravenous lines required attention. She went to his room to address it. As she adjusted the IV line, she glanced at his face. His eyes were open, as always, but something in his expression had changed. She couldn't describe it precisely. His features hadn't visibly moved. He remained unresponsive, still comatose by every medical measure. Yet something in his eyes appeared different. They seemed focused, no longer vague or random, but sharp and intent, as if he were consciously observing. She waved her hand in front of his face, checking for visual tracking. Nothing. She called his name and applied a mild, painful stimulus to his hand. No response. Every neurological assessment indicated deep coma, yet she couldn't shake the sensation that he was somehow aware, somehow present behind those unblinking eyes. She documented everything in his chart, noting the persistently open eyes, the unusual tracking movements, and the subjective impression of awareness despite an objective lack of response. She discussed it with Dr. Chen during his rounds at 6 o'clock in the morning. He reviewed the overnight electroencephalogram data, which showed slow wave activity consistent with deep coma, yielding no signs of consciousness or response to external stimuli. He reassured her that what she perceived as awareness was likely her own pattern recognition systems, attempting to find meaning in random biological activity. However, as the days progressed, the strangeness intensified. Martin remained comatose by every objective measure. No response to commands, no voluntary movement, and no change in his neurological status. His brain scans revealed significant hypoxic injury, precisely what would be expected after 12 minutes without oxygen. Yet his eyes remained persistently open, constantly moving in those small tracking patterns. Other nurses began to notice. Maria, who had been in the ICU almost as long as Dr. Hartley, mentioned it during shift handover on day 3, stating she felt uncomfortable in his room, as if being watched. Dr. Hartley understood exactly what she meant. Several nurses requested not to be assigned to his care, which was unusual, as they were accustomed to disturbing sights in the ICU and rarely shied away from difficult patients. Angela visited daily, spending hours at his bedside, talking to him, reading to him, and playing music she said he loved. She never mentioned the eyes. Dr. Hartley wondered if Angela noticed, if it disturbed her as it did the staff, or if a wife of 38 years perceived something different in her husband's unchanging gaze. On day 5, an event occurred that Dr. Hartley still cannot fully explain. She was checking Martin's vital signs around 3 o'clock in the afternoon. Angela was seated in a chair beside his bed, reading aloud from a book. As Dr. Hartley adjusted his ventilator settings, she saw his eyes move. Not the small tracking movements they had grown accustomed to, but a definite, purposeful shift. His eyes moved to look directly at Angela. Dr. Hartley froze, observing. His gaze was fixed on Angela's face, not random, not wandering, but focused, steady, and unmistakable. She reached for her penlight to test his pupillary response. The moment she moved, his eyes shifted to her, not following her hand or the light, but looking at her face. Direct eye contact was sustained for several seconds before his gaze drifted away again. She immediately called for Dr. Chen. By the time he arrived, Martin's eyes had reverted to their usual, unfocused tracking. Dr. Hartley explained what she had witnessed. He performed a complete neurological exam. No response to commands, no voluntary movement, and no signs of awareness by standard testing. The electroencephalogram remained unchanged, showing deep coma patterns. Dr. Chen documented her observation, but noted that without reproducible findings, it was challenging to interpret. He suggested it was possibly a coincidence, or perhaps her own perception filling in patterns that weren't actually there. But Dr. Hartley knew what she had seen, and she wasn't the only one. Over the subsequent 2 days, 3 different nurses reported similar experiences. Martin's eyes seemingly tracking people, making direct contact, and focusing with an intentionality that contradicted his comatose state. Yet, every time they attempted a formal assessment, every time they brought in a doctor or conducted systematic testing, the phenomenon would disappear. His eyes would revert to random movements, and he would display no signs of awareness. The medical team initiated discussions with Angela concerning Martin's prognosis. 7 days had elapsed since his cardiac arrest, yet his neurological state showed no signs of improvement. Extensive damage was revealed by brain scans, and the electroencephalogram displayed an absence of meaningful activity. Clinically, a recovery for Martin appeared highly improbable. Angela was faced with a horrifying dilemma: maintain indefinite life support, or permit him a natural passing. She pleaded for additional time, wishing for her children's arrival and every possible chance for his condition to improve. On the 8th day, I was once again on the night shift. The ICU was short-staffed, with only 2 nurses attending to 12 patients. My assignments included Martin and 5 others. Around midnight, I entered his room to turn him, a routine to prevent pressure sores, as prolonged immobility in hospital beds can lead to skin breakdown. As I maneuvered him onto his side, his eyes met mine directly. It wasn't the vague tracking I had grown accustomed to. Instead, it was clear, focused eye contact. And this time, emotional content was present in his expression. Not quite emotion, nor consciousness as we typically define it, but a sense of recognition, perhaps acknowledgement. I struggle for a more precise description. I addressed him. "Martin, can you hear me? If you understand, try to blink." There was no response. Nothing. I issued other commands. "Squeeze my hand. Move your foot. Make any movement you can." Still, nothing. By every conventional test, he remained utterly unresponsive. Yet his gaze remained fixed on mine, and I was overcome by an absolute certainty that he was somehow present, somewhere behind those eyes. I lingered in his room longer than necessary, observing him, attempting to decipher what I was witnessing. Eventually, I had to attend to my other patients, but the image of his eyes persisted in my mind. That focused, deliberate stare, the profound feeling of being seen by someone who, according to all medical evidence, was unconscious. The following morning, I reported the incident in meticulous detail. The neurologist ordered a complete reevaluation, including more electroencephalogram monitoring, another brain scan, and additional tests. All results were consistent: deep coma, severe brain injury, and no indications of meaningful neurological activity. The medical consensus remained firm. Martin Kellerman was in a persistent vegetative state subsequent to cardiac arrest, and his prognosis was bleak. However, I embarked on research. I accessed medical databases, searching for comparable cases. Comatose patients with unusual eye movements, awareness in seemingly unconscious individuals. I unearthed sporadic references to something termed covert consciousness. These were instances where patients appeared completely unresponsive via standard testing, but exhibited signs of awareness through more sophisticated monitoring, such as functional magnetic resonance imaging studies, that revealed conscious thought in patients diagnosed as vegetative. It was a rare, poorly understood, though documented phenomenon. I presented this information to Dr. Chen. He listened respectfully, but underscored that we lacked access to functional magnetic resonance imaging. And even if we had it, it wouldn't substantially alter Martin's situation. His brain damage was extensive. Even if a fragment of awareness endured, his capacity for recovery was minimal. The compassionate course of action, he posited, was to allow his family to make end-of-life decisions rather than prolonging his suffering. On day 10, Angela made her choice. She would withdraw life support. She had consulted with her children, with the hospital chaplain, and with her own conscience. She could not bear the thought of Martin indefinitely trapped in a broken body. The plan was set for the following morning: disconnect the ventilator, cease intravenous medications, and allow him to pass naturally. Given his condition, doctors anticipated his demise within minutes to hours. That final night, I volunteered to be his nurse, feeling it was a duty owed after caring for him throughout his hospitalization. I wished to ensure his last hours were as comfortable as possible. Angela remained until midnight, then departed for a few hours of rest before returning for the withdrawal procedure. Alone with Martin in the quiet ICU, I performed my duties automatically, checking vitals, adjusting medications, repositioning him. His eyes remained open, as always, exhibiting their usual tracking patterns. I found myself speaking to him, despite knowing he couldn't respond. I conveyed his wife's love, his children's impending arrival, and that it was permissible to let go. I cannot ascertain if any part of him registered my words. Around 3 o'clock in the morning, while charting at his bedside, his alarm sounded. His heart rate had plummeted abruptly. I glanced at the monitor. 60 beats per minute, then 50, then 40. Not yet a critical emergency, but certainly concerning. I summoned Dr. Chen, who was making rounds in another unit. As I waited, I observed Martin. His eyes were once again fixed on me, with the same intense focus I had witnessed previously. But this time, something was different. His eyes were moving. Not random tracking, but deliberate, rhythmic, purposeful movements back and forth, left to right, right to left, repeatedly. I suddenly recognized his action. He was attempting to shake his head. His neck muscles were unresponsive, his body still, but his eyes were enacting the motion. "No," he was conveying. "No." "Martin," I uttered softly, "can you hear me?" His eyes ceased their lateral movement, locking onto my face, fixed, steady, unwavering. "If you can understand me, move your eyes up and down." For a moment, nothing. Then, slowly, deliberately, his eyes moved. Up, down, up, down. Ice coursed through my veins. This was impossible. Every test declared him comatose. Yet he was responding, communicating, aware. Dr. Chen arrived, and I breathlessly recounted what I had just witnessed. He was skeptical, but willing to investigate. He issued the same commands. "Martin, if you can hear me, look up." Nothing. "Look down." Nothing. "Look to the left." Nothing. Absolutely no response. "I swear to you, he did it," I insisted. "He was responding to my commands." Dr. Chen was gentle yet firm. He suggested that after 10 days of vigilance, lengthy shifts, and the stress of this unusual case, I was likely exhausted. Perhaps I had perceived what I wished, hoped to see. He asked me to take a break, get some coffee, and clear my head. I left the room feeling shaken and uncertain. Had I imagined it? Was I so invested in finding awareness in this patient that I had fabricated it from random eye movements? I went to the break room, made coffee I didn't drink, and tried to organize my thoughts. 20 minutes later, I returned to check on Martin. Dr. Chen had departed to attend to another patient. Martin's eyes were open, tracking aimlessly. His heart rate had stabilized. Everything was quiet. I approached his bedside. "Martin, if you are in there, if you can hear me, I need to know. They are going to withdraw life support in a few hours. If you are aware, if you understand what is happening, you need to show me, please." For a long moment, nothing. Then his eyes moved to my face, fixed, focused, and slowly, deliberately, they moved up and down. Yes, I have revisited this moment countless times since, pondering what I should have done, what I could have done. I should have immediately called Dr. Chen back, demanded more testing, advocated more vehemently for my patient. But I was paralyzed by doubt. Every objective measure indicated Martin was comatose. One nurse's subjective interpretation of eye movements was insufficient to override comprehensive medical assessments. Who was I to declare the tests erroneous? Instead, I meticulously documented my observations in his chart, noting the apparent responsive eye movements, my concerns about potential covert consciousness, and my recommendation for additional evaluation before proceeding with withdrawal. I recorded the time, specific commands, and responses, ensuring it was officially documented. Angela arrived at 7 o'clock in the morning with her children. The family spent an hour with Martin, bidding their farewells. I remained in the room, monitoring his vitals, affording them privacy while remaining accessible. Throughout this time, Martin's eyes slowly tracked around the room. At one point, they settled on Angela's face for several seconds. I witnessed her gently caress his cheek, tears streaming down her face. At 8:30, the medical team assembled. Dr. Chen reviewed the plan with the family. They would first reduce his sedation medications, affording him an opportunity to exhibit any signs of awareness. If he remained unresponsive, the breathing tube would be removed. Angela and her children consented. The sedation was halted. We waited. Standard protocol allows 30 minutes to an hour for the medications to dissipate. Everyone observed Martin intently, searching for any sign of consciousness, movement, eye opening, response to voice. But his eyes were already open. They had been open for days. Furthermore, he showed no response to the commands issued by the doctors, except to me. When no one else was directly looking at him, when the doctors spoke to the family, when attention was directed elsewhere, his eyes would find mine, and he would perform that same lateral movement back and forth. "No, please, no." I spoke up. "Dr. Chen, I genuinely believe we should conduct more testing. Functional magnetic resonance imaging, advanced assessment protocols. I understand this is unusual, but I don't believe we can be certain he lacks awareness." Dr. Chen drew me aside, speaking quietly but firmly. He understood my concerns. He had reviewed my chart notes, but 10 days of comprehensive monitoring had yielded no evidence of consciousness. The eye movements I was interpreting as communication were, most likely, random motor activity. Prolonging life support when recovery was impossible was not in the patient's best interest. The family had made an informed, loving decision, and we needed to respect that. By every reasonable medical standard, he was correct. I possessed no objective proof, merely an intuition, an interpretation, an undeniable conviction I could not substantiate. At 9:15, they removed the breathing tube. Martin's heart rate showed a slight elevation. His oxygen saturation began to decline, yet his lungs failed to initiate autonomous respiration. The brain damage was too severe. His bodily systems were shutting down. I held Angela's hand as we fixated on the monitors. His heart rate plummeted. Oxygen saturation dropped. Blood pressure fell. The clinical march toward cessation. It spanned 40 minutes. 40 minutes of witnessing a man's body cease functioning, observing the diminishing readouts, watching life recede. And for every single one of those 40 minutes, Martin's eyes remained open, tracking, moving, directing their gaze at each of us in turn, his wife, his children, the medical personnel, and repeatedly, persistently, at me. At 9:57, his heart ceased beating. Dr. Chen pronounced him deceased. His family was overcome with sorrow. I assisted in disconnecting the monitoring equipment, prepared his body for the morgue, and performed the final duties we owe our patients. But I could not erase the image of his eyes, open until the ultimate instant, until the final beat, fixed on me, attempting to convey something I had been unable to perceive, striving to communicate something I had failed to grasp. This case has resonated with me daily ever since. I have pursued research into covert consciousness with unwavering dedication, uncovering dozens of documented instances in medical literature where patients diagnosed as vegetative were subsequently discovered to exhibit awareness. Studies suggest that up to 20% of patients considered unconscious may in fact possess some degree of awareness, with emergent technologies revealing conscious thought in seemingly unresponsive brains. Conversely, I have also found solace in some of the same literature. Even in individuals with covert consciousness, the level of awareness is frequently minimal. Perhaps Martin was not fully aware, was not in agony, was not desperately trying to communicate. Perhaps what I interpreted as deliberate eye movements was, indeed, random neurological activity. Perhaps my guilt over failing to save him is unfounded because there was nothing to salvage. Yet I do not believe that. I cannot believe that, given what I witnessed during those final 40 minutes. I saw a man imprisoned within a failing body, incapable of speech, unable to move, able only to move his eyes. And I saw those eyes pleading with me not to let him perish. I reported the incident to the hospital ethics committee. They conducted a thorough review and concluded that all established protocols had been adhered to. The medical decision-making was sound, based on the available evidence. The family's choice was both ethical and compassionate. My concerns, while acknowledged, lacked objective support. I continued to work in the ICU at St. Catherine's, still caring for comatose patients, still monitoring unresponsive bodies sustained by life support. However, my advocacy has evolved. When families confront decisions regarding withdrawal of care, I now press more vigorously for comprehensive consciousness assessment. I discuss covert consciousness, the limitations of our testing, and the possibility that awareness might persist even when we cannot detect it. Some of my colleagues believe I am excessively cautious now, too willing to prolong suffering for an uncertain benefit. Perhaps they are correct. Perhaps I am allowing one ambiguous case to overshadow decades of medical evidence and clinical experience. But every time I encounter a patient with open eyes, every time I observe unusual tracking or movements, I recall Martin Kellerman. His case fundamentally altered my nursing practice. It impressed upon me the imperfection of our tools for measuring consciousness, demonstrating that absence of evidence does not equate to evidence of absence, and that sometimes truth occupies realms our machines cannot reach and our protocols cannot quantify. I frequently think of Angela. She made the decision she believed was appropriate based on the information provided by her medical team. She acted out of love, striving to prevent her husband from existing in a state devoid of quality of life. I believe she made the choice most of us would in similar circumstances. She should not bear guilt for what she could not have known. But I carry enough guilt for both of us because I did know, or at least I suspected, and I did not contend strenuously enough. I deferred to authority, to protocols, to objective measurements that might have overlooked something critical. I was the lone individual who might have afforded Martin more time, more testing, more opportunity to substantiate his presence. And I failed him. The question that torments me is not whether Martin was conscious. I know he was. I perceived it in his eyes, in those deliberate movements, in that final, desperate gaze. The true question is whether it would have mattered, whether, with additional time, improved testing, and different decisions, he could have recovered sufficiently to communicate, to interact, to experience any quality of life. Or whether he was forever entrapped within that shattered body, and my instinct to save him would have merely prolonged his suffering. I will never ascertain the answer. Martin died with his eyes open, looking at me, and I will never know if I acted correctly by letting him go, or if I abandoned a conscious man to death. What I do know is that I will never view a comatose patient in the same way again. I will never assume that open eyes signify nothing, that absent responses prove unconsciousness, that our tests reveal all there is to comprehend about the mind confined within a deteriorating brain. Because sometimes, rarely, impossibly, awareness perseveres in places we do not anticipate. Sometimes consciousness conceals itself behind unresponsive bodies and negative test results. Sometimes a patient's eyes narrate a story that our machines cannot decipher. And sometimes, in the intensive care unit, in the realm between life and death, a nurse perceives something that medicine cannot elucidate and cannot dismiss, something that alters everything she believed she knew about consciousness, about death, about the limitations of what we can measure and what we can truly know. Martin Kellerman's eyes would not close, and now neither will mine. I see him in every comatose patient. I seek him in every unresponsive face. I search for that same focused gaze, that same desperate communication. I have not encountered it again. Perhaps I never will. Perhaps Martin was singular, a rare instance of awareness within apparent unconsciousness. Or perhaps I fabricated the entire experience, discerning patterns in randomness, imbuing neurological noise with meaning. But I do not believe so. I believe he was present. I believe he was aware. I believe he was attempting to tell me something, and I proved incapable of saving him. That is the case that continues to unnerve me. Not because of what I witnessed, but because of what I could not achieve. Not because of the medical enigma, but because of the human being I might have failed. The patient whose eyes would not close. The man who might have been conscious when we allowed him to die. The case that taught me that sometimes the most disquieting aspect in intensive care is not what you see, but what you cannot prove, what you know but cannot demonstrate, what your instincts clamor, but your protocols deny. In 23 years of ICU nursing, I have encountered death in its myriad forms, but only once have I witnessed someone die while their eyes implored me not to let it happen. That image will remain with me eternally.